All right. Good morning, everybody. Welcome to the show. Another episode of Private Practice Practically. On today's episode, we have a very, very special guest, Dr. Scott Miller, prolific writer, written, what is it now, Dr. Miller? Hundreds of articles, maybe written and co-authored.
Yeah.
Where you at?
It's in the hundreds.
10 or 12 books now?
Yeah, that's about right.
Wow. Just an amazing writer, what I consider to be a thought leader in the field. Dr. Miller, would you mind telling everybody who doesn't know you or of your work a little bit about you and how you got started in the work that you're doing now?
Sure. I am Scott. Please call me Scott, and a psychologist. I've been in the field since the late 80s. And I think that what I'm perhaps best known for at present is our work on deliberate practice. But deliberate practice follows a long exploration and lots of research aimed at trying to uncover, discover, help therapists figure out how to improve their craft. And in terms of that, I don't mean just in the approach that they're using, but also the outcomes. There's some fairly astonishing, I would say, data about our profession. And that is that our outcomes have remained flat since we first started measuring the results of psychological care. We are not improving. And so that's a challenge. Our models have changed, they've proliferated. We have a growing and shrinking diagnostic and statistical manual. All of that data, I should also mention hours of supervision, longer training in order to enter the field. None of it has moved the needle in terms of performance in that period of time. And for me, that was deeply troubling, especially given that I would categorize myself as an anxious therapist. I want to help people, and I don't feel satisfied. I never did from my earliest days by explanations that sort of shifted the burden of poor outcomes or lack of outcomes to our clients. So they're too ill, they've been a problem, they can't form a helping relationship. Not satisfying to me. Or maybe the other side, which is our models. Well, I just need to learn this technique or that technique. And if you've been around for any length of time, you probably know that our field seems to adopt these new approaches with a speed rivaling changing skirt lengths and lapel widths on a French fashion runway. But it doesn't amount to much in terms of service to our clients.
Wow, Dr. Miller, that's so interesting. I'm sure that this the world of efficacy in mental health outcomes has been researched for a long time. Does that research still support, like all the modern research that you've looked at, still support this idea that we're not really being effective, even though there's, EMDR is out, we got CBT, we got all these new evidence-based practices, and are you still seeing that the research shows that not a whole lot of difference between them?
So if the question is, are we effective? That's really the paradox. All of the data indicate that therapists help their clients on average between 50 and 65% of clients are measurably improved by the end of treatment. But that leaves 35 to 50% who aren't helped by the work that we're doing with them. And the question for me has always been, what do we do with those people? Do we even know who they are? Combine that with the fact multiple articles indicate that we clinicians don't seem to be aware of when we're not helping. We actually overestimate our effectiveness, probably to the tune of 50 to 65% on average. So that doesn't mean we're not effective, but when we look at the particular models and the trajectory over time, those changes have not made us more effective. And that really causes panic amongst folks, I would say, commensurate with or equal to the degree of commitment one has to their particular approach, whether that's EMDR, CBT, et cetera. Once you do the right kind of research, which is comparing like to like within the same study, you don't see meaningful differences in the outcome, not at least the kind of differences that you would hope would be there given the investment it takes to learn these models and be trained in the field and licensed to practice independently. So I would say that that kind of training really isn't the avenue to greater success.
Wow, yeah, that's really, really interesting. And one thing that stood out to me about your previous answer was that you were an anxious therapist. And I like to kind of go back in time a little bit. When did you realize, recognize that feeling within yourself? And then what led you to start the Center of Excellence as you kind of develop some of your work?
Well, this is a feeling I've never gotten over. So I'm still an anxious therapist. In the meeting, I want to do and say the kinds of things that are engaging to the person that I'm working with and also ultimately helpful. And that dates back to my earliest years as a practitioner, even and as a practicum student, anxious about whether or not. Now I know nowadays people call it the imposter syndrome. It's not a term that I really like. I think not feeling like I truly understand someone else and wondering if I'm going to be able to be of help or know enough to be able to help. I would say that is actually the foundation of being able to help, to remain curious and interested, always open to possible ways to connect and to make a difference in people's lives. So again, it's not a feeling for me that has vanished. I think that if it does, that is probably an issue that needs to be addressed. And I'd like to look at your results and see if they're commensurate with somebody who's very confident. And that's the confrontation I had as a graduate student, that people seemed much more certain to me about their pronouncements, about both their diagnostic pronouncements and what they were supposed to do in the room. Their confidence about the approach that they were using was surprising to me. And again, remember, on average, clinicians are not helping between 35 and 50% of their clients. What happens to those clients? Well, a couple of things. They stay in care without changing, or they drop out and begin to search from one therapist to another, which is a fairly common kind of experience for consumers of psychological care, that they see multiple therapists.
Yeah, that's so interesting, Dr. Miller. And I think I've been there in the past where like I'm hearing certain speakers and even certain supervisors and clinicians kind of talk about their craft or their approach. And there's so much certainty sometimes. And I'm like, how do we know for sure, right? Like we're so complex as people and as clients. How do we know for sure that what we're doing is being effective? And what you're saying makes a lot of sense, that we are being effective. But there's some clients that may not be receiving some of that particular style, so to speak. And I think that makes a lot of sense. Scott, I wonder, with that being said, you mentioned the word imposter syndrome, and I've seen that a lot on the Facebook groups. People are posting about it, they're writing about it. But one thing you said stood out to me though was that you said it can be foundational. Can you kind of expand on that a little bit?
Well, if you are open to feedback from external sources, namely your client, or from feedback measures that are administered on an ongoing basis, if you're open to that, you tend to have better results. So I don't mean self-doubt that is critical, but self-doubt that causes us to reflect and to question. It's the kind of experience I have driving home from the office, and I'm thinking about that last client that I had and wondering if I said or did or what I could say or could have done that would have made more an impact. So that's what I mean, transforming this term imposter syndrome as if we could open your head, fill it full of the right information, and then it would go away, as a misnomer. I like to think of self-doubt as essential, as a foundation for openness to working differently, hearing differently what our clients are saying and what might be of help.
Yeah, that's so interesting. And Dr. Miller, in your opinion, why do you think that therapists just in general kind of lead with their credentials, like their training, like CBT, DBT focused? Is that part of kind of this culture that we're in, potentially, like that stems back to grad school maybe? Or does that give us like a certain confidence? Like, I know what I'm doing, like what are your thoughts on that?
I haven't ever researched why that is. So I don't know. I certainly have some opinions, and my opinion is that that's what the market responds to.
Mm.
So in our field, in the broader field of medicine, particular drugs, for example, name brand drugs, get a response, and they're usually connected to some pretty picture about great outcomes. Second piece, so I think it's market. I think the second piece is that we think like physicians, and our field, unfortunately, doesn't work like medicine. So in medicine, we're looking for so-called specific ingredients that is ingredients that are remedial, specifically remedial to the problem being treated. The simplest example of that is antibiotics. You go to your physician's office, you have strep, you want an antibiotic, not aspirin. Will aspirin help? Yes, it will be helpful in terms of pain and suffering, but it's not going to directly attack the cause of the problem. So our field has emulated that idea that within these models are contained ingredients that are remedial to the cause of that problem. So for a long time, we thought that depression, for example, was caused by negative thinking. Well, there really isn't a whole lot of evidence for that. All the models seem to work about equally well, whether you're focused on feelings, on behavior, on thoughts, or on your childhood. They all seem to work relatively well with most clients. So psychological care just doesn't work the same way as medicine, but being steeped, especially in Western culture, in that idea, we highlight the model that we're going to use. And the latest of those is trauma-informed therapies, that somehow we're addressing it in a specific way the underlying causes of whatever the consequences of early childhood or life trauma that people experience. And I just don't see a whole lot of evidence for that.
Yeah, and that has become a very popularized term, trauma. I see almost everybody specializes in trauma, and there's nothing wrong with that. I think, especially, going back to what you said, that's what the market responds to. And what's also interesting is that in your work, you describe how there's no difference really in between therapist, seasoned therapist, mentalists, even tarot card readers, right? And so I wonder, Scott, if you can kind of share with us a little bit more about that, that there's really no difference between all of these modalities, and then even if we open up the aperture a little bit, even between like mentalists, the psychics, the tarot card readers, and just kind of really what's important, I think, is what you've said all along, and which I read and found out about in your work, is that just entering their worldview, fixing auras, right? Like whatever the client responds to.
Yeah.
I think that's phenomenal. So would you mind telling us a little bit more about that?
So there are differences in outcome between therapists. That was evident as far back as the 70s, when one researcher in particular examined a small number of therapists and found that the best predictor of the outcome was who had treated the person. And we've known that between 5 and 15% of the variability in outcomes is directly attributable to who provides the treatment. And when clients ask me, who should I be treated by? I say, that is the right question. Not what method and what's your diagnosis, but who is the best person that's going to treat me. But until recently, we really haven't had the ability to look more closely at what it is that's causing these differences. And even if you carefully control a research study, degree, training, the use of a particular model, differences between therapists emerge. When experts can't distinguish, looking at the recordings of the session, they can't distinguish on the basis of those characteristics I just mentioned, any differences between the therapist and what they're doing in the room. So the therapist is an important variable in the outcome of psychological care. So that's what we started looking at 15, 16, 17 years ago, and what it was that contributed to these differences. And that's what led us to in part deliberate practice. Therapists who were more effective than other therapists, their outcomes were less variable to begin with. Secondly, they had better outcomes with more difficult types of people to work with. And third, they seemed to engage in this activity called deliberate practice, where they spent a lot more time focused on the people that they hadn't helped, looking for deficits in performance that they could then rehearse and practice and get consultation about. And that's what our last two books were about. Deliberate practice, or the two books are Better Results and A Field Guide to Better Results. And this is an area that is really, I would say, current in the research literature, or on the cutting edge, so to speak, trying to understand what it is these better therapists are actually doing. What we can tell you is that it has nothing to do with the particular model they choose to use, or even their diagnostic acumen. One key finding from this is that the top therapists seem to have mastered the core clinical conditions: empathy, respect, genuineness, careful listening, verbal fluency. These are variables that these better therapists seem to have a more of a grip on. But we're still in the process of teasing all of that out. The research that you're citing about psychics was a result of trying to look outside the field. Since the field had not been able to give us any information about how to differentiate the best from the rest, we started to look outside to other performers that seem to connect very easily with people: mentalists, people who read your mind, so to speak, psychics, who, whether you believe that they have some special power or not, often form very intense bonds with people. And people are very committed to what they've been told about themselves by these folks, or a tarot card reader. And of course, what we found is that many, many people sought out help from such providers, and that their outcomes were largely indistinguishable from practicing therapists. Published a couple of articles, research articles, about that. And one of the pieces of difference between psychics and the therapists was that the psychics seemed to be willing or able to align a bit better with the client's worldview. So therapy models are deeply materialistic. That's not a criticism, that's a description. Whereas the psychics were willing to go into a different area, and I'm fully willing to admit that some therapists are willing to do that as well, into a spiritual realm, into a realm of there's more to the world than our models seem to say or cue us about.
Yeah.
But the big key finding was that folks that were not trained mental health providers also had very, very good outcomes. But again, our attempt was really to find out, well, what is it that those people are doing? Maybe we could learn something from them.
Yeah, that's so incredible. And I remember in one of your interviews, interview videos that I watched, you were mentioning the, I think it was British therapist who had really exceptional outcomes, and she would do certain things for the clients that would make the clients really respond to her. Can you share a little bit about that?
We've interacted with so many of what are now called super shrinks,
Yeah.
that these are therapists who seem to have uniquely better outcomes. And I think the person you're talking about here was one of our key first interviewees in that super shrink project, looking at people who were exceptional in connecting and helping clients achieve outcomes. Her name is Wendy Amy. And we wrote an entire article, really, that was published in the popular psychotherapy magazine, Psychotherapy Networker. And really, Wendy was just much more curious than others. She instantly said, and by the way, we didn't tell her that she was a super shrink. She just happened to be using our measures. And when we were looking for people to interview, we looked at we took those off the top and started talking with them. And Wendy was unusual in the fact that she embodied self-doubt. It wasn't that she wasn't caring or even confident that they would eventually figure it out, but it was truly her self-doubt, her professional self-doubt, that led her to seek out additional resources outside the room to talk to others. She described herself, for example, in one of our interviews as not a cause, but a conduit to her clients for change.
Wow.
So she was sort of piping in different resources from to inform the work that she was actually doing. In addition, when she got feedback, she often took a lot of time after the session to process this, transform it into things that she could practice, and then rehearse it before delivering it to the next person. She did this in a thoughtful and planned way. There's lots of extracurricular activity, in other words, that these top performers are doing much beyond simply attendance at continuing education events. And I'll say something about CEs. Number one, not much evidence that they make much difference in outcome. There simply isn't. So we're all mandated to earn a certain number of CEs. I'm not upset with that, because the research also shows that if they're not mandated, lots of people don't get any training. But here's a more disturbing fact about continuing education. The evidence seems to indicate, and this is a thin level of evidence, but it's there, that attending such events reinforces the worst aspects of how clinicians learn. Clinicians often go and their confidence increases after attending such events. What have I said this entire conversation? I've said confidence in many ways is the enemy of improvement. That if you feel fairly confident about your work, why would you need to change or learn anything? If you attend a CE event and you come away saying, yes, that's how I work, or I feel better now that I've learned this technique, I think it will help me. What's your evidence that that will make a difference? So here's the solution in part. Measure. If you really want to improve, then measure your results and start to look at your outcomes. Look at the people that you are not helping. I think you'll be surprised at the number.
Wow, Scott. Yeah, that's kind of runs counter to a lot of the things that we kind of think, in the way that we think, is that, you go to a CEU and you get confidence, and you feel good about your craft, but what I'm hearing is that sometimes it's the uncertainty and the little self-doubt that makes us want to improve, thereby seeking out additional supervision or coaching, and the extracurricular activities that you talked about. And it really sounds like some of those super shrinks really have a system of improving. For the young clinician that's entering the field, and they're not introduced to this idea of building a system that makes them better, and they're kind of fighting against, and not fighting, but they're in this model of, or in this world of, like, build confidence. Here's what you need to buy next. Here's the level 2. Here's the next program. How can they begin to develop that system to improve, if they recognize, okay, I do have some self-doubt. I do probably know I should improve. What's kind of like the first few elements to building that system out?
Well, let me just go back to what we were talking about just a second ago, and say that I do think many clinicians are uncertain and have self-doubt. I just don't think there's much of a space for it.
Gotcha.
A space for conversation or for admitting. And that when you do talk about it, then you have a leader, an expert, a supervisor who's very willing to mollify those anxieties by saying, if you knew what I knew, if you did what I did, if you bought my book, then you would be more confident. That's the way to solve this, even though that's what our field has now been doing since basically Freud. And it doesn't seem to work, but it's almost self-perpetuating cycle. So I think here's another interesting stat.
Yeah.
There's no difference in outcome in the main between students and their supervisors. So what exactly are they being supervised to? In fact, there's data that indicates that in many cases, the students have better outcomes than their supervisors. What's that about? And what are we supposed to do about that?
Yeah.
This, for me, has some instant implications. Why do we assume that students who are entering the field are ineffective helpers until they're trained? I think there's no evidence for that. In fact, I think it's a real distortion. So what we could do, instead of teaching or inculcating a certain point of view or values, is we could begin to respect the diversity of ways that people can help and can be helped. That connects back to the psychics and the tarot card readers. Now, I'm not suggesting we teach tarot in graduate school programs. There's a particular tradition of modern westernized mental health. But I am suggesting that if you've been living and breathing in this world, that you already have some ideas, and it's a highly select group of people who make an application for graduate school as a marriage and family therapist or a social worker or a psychologist. This isn't the broad society. This is a group of people who see this as part of who they are. And I would say that maybe what we need to do is support them. And so an easy way to do that would be to begin to measure the results of people the minute they enter an apprenticeship style school or training program. And we can begin to help them identify their blueprint for helping to make that implicit explicit, and then highlight whatever weaknesses or deficits that we find via measurement. Maybe you have better outcomes when you're working with someone who shares your same gender identity or particular issues or concerns or cultural background. Knowing that might help us tweak and point to some broader experiences that they could have that might help them develop a broader set of skills. Wow. So I think there is that all of this data seems to suggest that the paradigm needs to change and be altered.
Yeah. Wow, Scott, you in some of your work, you mentioned that I believe it was something like 80% of clinicians think that they're more technically capable than their peers. Is that stat correct? And can you tell us more about that statistic itself?
So the very first study to talk about this was, I believe it was called something about Lake Wobegon, and it was done by Mike Lambert and some colleagues. And they asked a group of therapists to rank their effectiveness relative to others. And the average therapist thought that they fell at the 80th percentile. Well, you know about percentiles. That means you think you're more effective than 80% of your colleagues. The problem was that doesn't make any sense. The average therapist thinks they're better than 80% of their peers in terms of outcome. But mathematically, it's impossible. The other interesting piece about this study was that virtually no one thought that they were below average. So that's just a fact of human nature. It's not specific to therapists. The same thing applies to lawyers, to physicians, and here's an interesting thing, professors in university. They often see themselves as far more helpful and effective than all of their peers. So that's just a human blind spot that we have to attend to. The way to have a more realistic view of your abilities is to measure your results and see where you line up. Now, the good news is that most therapists fall around the 50th percentile. So we're mostly pretty average as therapists. So we're talking about a very small group of clinicians, maybe 15, 16% of the total number of clinicians that have super shrink status like that. Yeah. So I often tell people that the most frightening thing you're going to find out about yourself when you begin to measure is that your mother was wrong about you. You're not special in any way. You're just like everybody else. Moving from that spot to a little bit better is the challenge in our field, especially given the tools that we are trained to use. Without adding the measurement piece, I think that you're going to be searching for a long time with not very good results in terms of improving.
Yeah, and what's striking to me, Scott, is that if 80% of or if clinicians rank their effectiveness at that percentile, does feedback feedback informed treatment or the work that you're doing actually have traction with the average clinician. If
Mm.
people already think they're better than their peers at some level, like maybe they look at this like, well, I don't need that, I'm already pretty solid.
Yeah, I think that's generally true. And it's not just true in mental health. You would hope we'd be more aware than that, or not. The same thing applies to driving. The average driver, almost exactly the same stats. The average driver thinks they're better than 80% of the people on the road. Um, uh, so it does require intervention. And I would say that feedback seems to be only part of the solution or the key to this, because people like Kim De Jong out of the Netherlands is looking at why some therapists take up feedback and others do not, why it seems to have an impact on some and not of others. I mentioned earlier in our conversation this thing called an external feedback propensity. So if you have an external feedback propensity, meaning that you are more open to what others say and comment on, then you're more likely to see feedback as critical, and the feedback's likely to make an impact. If you are self-reliant, internal feedback propensity, you listen mostly to your own voice, well, then providing you with feedback doesn't have as large of an impact on your performance.
Wow. Yeah, that's fascinating. Yeah, I'd be really curious to kind of follow along in his research or her research. I'm not familiar with that researcher, but to see
Yeah.
what comes out of that, because that's so fascinating.
Yeah.
Um, Scott, yeah, follow-on question, for the clinician that hears this feedback, watches this video, maybe gets in and starts interacting with some of the work you do, and they say, all right, maybe this is a good idea for me. Maybe I do want to get better. I want to help more people and be more effective. What can they do to be able to reach out to a coach or a supervisor that embodies some of the work that you're trying to spread into the world?
Mm. Well, I do think that it's important to have a bit of a guide and a support group when you're trying to do deliberate practice and feedback informed care. And by the way, you can go to my website, scottdmiller.com. You can download the measurement tools for free. But if you don't have that guide, then I think the feedback is hard to make sense of.
Yeah.
So there is a discussion forum for the International Center for Clinical Excellence on Facebook. That is a private group where people meet and share questions and experiences with each other. You could attend one of the feedback informed trainings, and there you'll often meet this worldwide group of people that are doing feedback informed care in Europe, in Asia, in the United States, in Australia. It's actually a fairly large group. So that's the second. The third is to be patient. This is we're playing the long game here, not the short game. The promise, I think, of 2-day CE events is change your practice today. Learn about the brain in 30 minutes. Learn saccadic eye movements and release your clients from their traumas. That's not what you're going to get when you come to a feedback informed treatment workshop. We're going to say, begin to measure. Come back in 3 months. We'll talk about some of the information that you're getting. Have discussions with other clinicians who've been doing this for a while. And there are, I think, worldwide 150, 200 certified trainers in feedback informed work that can guide your interpretation of the feedback that your clients are getting you, understand all the statistical indices about your work that you're given when you begin to apply the measures in your practice.
Yeah, that's awesome, and it goes back to something we were talking about earlier, is having a system, having a community is very important to be able to use as a backboard, so to speak. Another concern I have, Scott, is this idea of insurance companies. They don't really pay for excellence, right? They're just essentially, in some way, just paying. Like, are you qualified? Do you have the credentials? Are you available? All right, this is your reimbursement rate. And so it's almost like we're in a world where it doesn't really pay to improve efficacy. What would you tell, or what kind of insight would you say offer to the clinician who's in that world? Like, well, I mean, insurance establishes my reimbursement rate. Like, they don't really, like, as long as I'm available in here, right? Like, what can we tell the clinicians in that mindset?
The person who is responsible for this term, deliberate practice, was a psychologist named Anders Ericsson, Swedish psychologist trained in Uppsala University, and then spent most of his career in Florida. And he was such a wonderful human being. We, early on in our work, found these patterns of top performers, but we couldn't explain it. They didn't seem to embody the Rogerian core conditions any better. They hadn't learned the latest technique. They didn't attend more CE events. They hadn't had more supervision or personal therapy. We had exhausted our usual categories for trying to differentiate the best from the rest. I happened to be reading an article on a plane in a magazine I'd never read before. It was just inserted in the pocket of the seat ahead of me. The magazine was Fortune magazine. And Jeff Colvin had interviewed this person named Anders Ericsson. And it wasn't about therapy. It was about his study of experts in a variety of fields: chess, music, medicine, teaching, computer programming. And when I read that article, it was like someone had opened the blinds. He was explaining how some became better in the same amount of time that the rest of us remain average over the course of our lifetimes. And I thought, oh my gosh. I went and I read everything I could find in the literature about him, written by him and his team. And then I called him on the phone. Amazingly friendly, very willing, and he consulted with us on all of the initial studies of deliberate practice. Okay, that's a long-winded explanation to get to the answer of your question. To Ericsson's death, the thing he said he puzzled over and could not figure out was why anybody would do deliberate practice. He said the incentives, again, not just within mental health and our insurance or crazy reimbursement system, but he says the incentives are all wrong. You work an incredible amount to achieve this much noticeable difference. Now, this much noticeable difference is the difference between Itzhak Perlman and a very good first chair in an orchestra. Right? So it's a small difference, but all of us look at it and go, that is excellence. He said he doesn't understand why anybody would do it. We think we have some ideas, but we don't have much research about it as of yet. For those who continue, the incentive is no longer money. The incentive becomes some internalized standard about the next challenge. This I haven't accomplished yet. Wow, I want to do that. And it's the achievement of that challenge that we think becomes reinforcing over time. As opposed to, if you think of the what I'm not saying, the self-satisfaction. Hey, I'm first chair.
Yeah. Wow. That's really good. Scott, can I take a quick second to close my window? I hear the trash truck coming and
Okay.
It's going to interrupt our feed. So I'll be right back into my second question.
All right.
Thank you. I'll edit that piece out. Yeah. What a great question, Dr. Miller. And I think that's so interesting because, I watched one of your interviews and the interviewer asked you specifically, said, so you've been able to delay gratification, and your response was, well, not necessarily. Like, I'm gratified by the challenge, by the uncertainty and the growth. And so in some ways, working on deliberate practice really is about achieving your best self, and just like a layman's term, a layman's phrase, right? Like, we're going to spend 10 or 15 years doing the thing. Might as well try our best at it and be deliberate about it and try to shoot for the first chair. Because right? Like, what else is there? What are your thoughts on that?
Well, I think that the definition that we use of deliberate practice is reaching for a performance objectives that are just beyond your current ability.
Mm,
So, and there's some wisdom in another thing that I think you've hinted at several times in the conversation, and that is about a system. And I think it was Scott Adams who said, average people have goals, experts have a system. So it is about working in a consistent way over a long period of time. Second piece is, what are the limits of my current abilities? Not identified by you, but identified by, say, something I mentioned before, measuring and looking at where you seem to do just fine and where your growth edge might be.
mhm.
So I think working that system and staying focused on that next achievable objective and doing so in a methodical way over a long period of time. What the data seem to say is that these experts in that process develop a more complex and nuanced mental map that not only gives them more choices in the moment, but the ability to synthesize a broader base of information in a creative way in moments that's needed in order to help the particular person or execute the skill that you are trying to execute. So I'm not a big fan of goals. If you've attended a training with me, I say, I don't really like them. I don't like them in therapy. I don't like them personally. I would much prefer that you had a system and direct knowledge of your deficits. And how do we get that? Again, you're going to have to measure and fine tune that. That's essentially what we talk about in the Better Results book. How to measure, how to look at the stats that measurement provides you with, and then develop a plan of remediation. Otherwise, the feedback that you get, you're going to be chasing a lot of ghosts, meaning that individual clients can always be accommodated for their differences, but that doesn't mean that difference doesn't translate into a deficit on your part. Much of what we do in the moment is simply random. We have to find the signal in the noise that speaks to your particular growth edge.
Wow. Yeah. And you mentioned earlier that if somebody were to undertake this and join your community, the Facebook group, and then they start experiencing a coach who asks for feedback and the measurement, and then they start kind of crafting a very personalized kind of journey in a way, they will ultimately, if what I'm hearing is correct, that it will be personalized. They'll have coaching that is very specific to the clinician, and it will improve what they're inherently kind of talented for. Is that kind of making
I think
sense?
50% of it is enhancing abilities, and probably the other 50% is identifying low-hanging fruit, so to speak,
Yeah.
deficits. So I'll give you an example. In general, therapists have an issue with dropouts. These are clients who come for a visit and then discontinue without warning and haven't experienced an outcome. That's a piece of low-hanging fruit. Let's look at the clients who don't return. What are their qualities? What did you do with them? What's the structure of your visits? And see if there's something we can change about that would have almost an immediate result. Then there are the longer term pieces where we just have to develop a broad enough base so that creative synthesis can take place at the moment in time it's needed in work with a given client.
Yeah, that's interesting. Dr. Miller, I wonder what the feedback has been from clinicians that participate in your programs, in your seminars, in your lectures. Like, what do they say after months and years of going through this process?
Well, I think I don't hear from the people who stop enough. We have just published a study out of a large cohort of practitioners in Vermont, and we were looking at this very question: why do some people pick up and stay measuring their results and others don't? And there were two sort of key findings from the study. One was that people who persisted, and this just speaks to human nature, I think, people who persisted with fit had an early ratifying experience. In other words, very early on in their exposure to measurement, they learned something from an individual client that made a big difference in the outcome. The longer it takes people to have a ratifying experience, the more likely they are to give it up, because you're not going to get critical feedback at every visit. In fact, you're going to get it seldom, because most of the time therapists, remember, 50 to 65% of clients get well. Most therapists do a pretty good job. We're average.
Mm-hmm.
So you're not going to get lots of feedback, which makes the process of administering and looking at the data, sorting through it, kind of laborious. There's not much reward. Those are those incentives that we talked about before. So I think that's one key element in the study that helped therapists continue and push through the doldrums, so to speak.
Yeah.
Another element in there was internal feedback propensity versus external feedback propensity. So how open are you to what other people say? And it can't be just in general. It has to be targeted to your specific needs or concerns.
Yeah, that's so interesting. Yeah, it makes sense that clinicians may not get that feedback, and in some ways, like, that initial hit of dopamine by learning and having that experience. Scott, I'm curious. I feel like the essence of fit is in some ways having to do with continuous growth and getting feedback to be better at something that we've decided to devote our lives to in many cases. And it can almost cross different domains of life, right? Like not just in the therapeutic office, but in other areas of life. And I wonder just kind of what your thoughts are about that. Like, are there lessons learned in this journey that can actually permeate into other areas of living?
Well, I think if there are lessons to learn from this, one is that you don't have to be an expert in every area, and you don't have to be improving in every area of your life. If you're satisfied with the way things are, then I would avoid measurement and deliver practice like the plague. At the same time, if you're devoting, as was Erickson's point, people devote their entire work lives to their work, and most of them don't get better at all. And in fact, most of us, our outcomes deteriorate over time. There's another kind of shocking finding. It's a finding that we published, must be 8 years ago now, and which has been replicated. It was one of the first studies to be part of APA's replication project because the findings were so controversial. Wow. But it holds up. Number one, we don't get better over our course of our careers. Every therapist you meet will say they are better. And based on their personal experience of their confidence level, my first practicum client versus my clients now, it seems like they're getting a much better service. Maybe it's smoother, but smooth and outcome, two different constructs.
Yeah.
And so the clients are not getting better results from that. So I would say one of the key lessons is, you don't have to be an expert. So choose carefully what you want to devote your time to. And if you don't want to invest the time, that's perfectly fine as well, as long as your outcomes are average, which is another lesson. So another lesson is that with agencies that say, oh, we're going to start to deliver practice, and I say, and you're going to incentivize that how? Because you really have no right to expect any better than average results from the practitioners who are being paid by you.
Wow.
Unless you're willing to devote more funding and resources to those people, that select few who decide to pursue that. That's another piece.
Yeah. Wow. That is just kind of mind-blowing to me, is this idea of like, when you're talking about group practices or practices or agencies that implement this, and that your initial thought or remark is like, hey, you don't have a right to demand more, right? Like, unless you're going to really incentivize this, because it is so laborious. It is challenging. And in fact, it kind of reminds me of a YouTube video that I watched a while ago, where one of the co-founders of Chick-fil-A said that it took them 3 years to adopt the My Pleasure company wide. And that's just saying a few words that the employees had to do. Like, I could only imagine like a whole system of feedback and measurements and tools. Although I do think it seems like it's worthwhile. Like, if we're going to devote our work life to this endeavor of helping people, then maybe there's something to consider, as far as trying to be the best that we can be through deliberate practice. Yeah, that's really awesome. One thing you said earlier, Scott, really stood out to me, was that time doesn't necessarily make us better. Can you tell us just a little bit more about that?
So, two things. The first one, and help me so I don't lose my train of thought here, is that it's interesting, this 3-year figure. We're one of the only evidence-based practices that have implementation research that we did, where we've looked at how long does it take an agency, for example, to adopt FIT, not even deliberate practice, but just this routine monitoring and utilization or exploitation of the data that we get for individual therapist improvement and improvement for the better results for the client. And the data says about 3 to 4 years. And that's with a persistent, dedicated effort. So FIT is not something that you're going to master in the short run. You can get started. It can be great. You can have an early ratifying experience. But in terms of complete application, we're talking about 3 years. Now, the second part of your question was?
Just the, you know what? I lost it also, but that's fine. I want to, you mentioned FIT and deliberate practice, Scott. I wonder, what's kind of like the construct of that? Like, does a clinician start their journey with your work with FIT, or do they go into DP? Like, how does one, like, what are the two options? And can you kind of help us understand the architecture of your work?
Well, I think that in terms of our discovery or research, it went from, wait, all models seem to work equally well. That's not a pathway, therefore, that's going to improve results. We could at least measure our results, because then we would know I'm helping this person, but not that person. I could focus my efforts there. And then this notion of, well, how can I improve as an individual clinician so I have better results? So DP. Personally, I don't know how you do DP without measurement. If in sports, I don't know how you would improve if they didn't keep score in some way. So I have no idea how that would happen. So you really do need to start with FIT. This has led some people in the field, and it's the Wild West out here right now as it applies to deliberate practice. We're just applying these ideas to psychological care. So there are divergent views about this. But there's always somebody in our field that's willing to tell you how to do it better. And I say, show me the data. Show me the data that learning this, rehearsing that makes a difference. I don't see any studies that suggest that.
Yeah.
So I think this is an individual endeavor. And that's because we're not having us adopt techniques and use them like surgeons. Scalpels can be rated on specific qualities and sold based on those qualities. Therapists cannot. Models cannot. They interact with us, our upbringing, our background, our culture, our worldview. They interact with all of that. So I put the therapist in the front of the equation. Know yourself. The way to know yourself, in part, is to begin to measure and look, when do I help? Who do I help? Where do I not help? Where am I? With whom am I less helpful, etc. By comparing my practice to standard norms for clinical practice. So I think you got to start with FIT first to identify some initial deliberate practice goals.
Got it. Okay, so FIT is the measurement component. Deliberate practice is kind of like the interpretation and the establishment of the system. Is that kind of like a fair summary?
Yeah, I think so.
Okay, got it. And I like to go back. You asked me what the second part of my question was, and I remember it as you were talking. Or answering. Yeah. So the second part of the question was, if you can tell us a little bit more about this, your studies about how over time we don't necessarily get more effective or better.
Right.
And going back to what you said even earlier than that, was that the studies show that maybe the opposite is the case.
Yeah. So that's just a statement of fact. Most therapists, as I say, don't believe that. They actively and hotly contest the idea that they're not better than they were when they were, say, a graduate student.
Mm-hmm.
But the data show what a lie that is. It's just simply not true. Students have just as good of outcomes or better than their supervisors. That's not a fact to dispute. It's a fact to contend with. Well, what's the purpose of training then? And if we don't ever get beyond this medicalized view of psychological care, which is, I'm going to train you to deliver the ingredients specifically remedial to clients' problems. That's what I'm going to do. If we don't ever get beyond that, then we are never going to improve our outcomes, which have remained flat for the last 50 years.
Oof.
So just absorb that for a second. Expanding diagnoses, expanding treatment approaches. We have a whole generation on TikTok identifying with their diagnosis and treatment approach, and it makes no difference in outcome.
Wow.
No consistent difference, nothing that you can learn from that and apply to better improve your outcomes. And that just sets the challenge for those who want to get better at their craft, those who want to improve. Now, there are many other variables on which to base or assess a clinician's competence. You may be particularly good, for example, at attracting people to your clinical practice versus others. That's not what I'm talking about. That is an amazing skill. To attract people and keep them in clinical practice. What I'm talking about is the outcome here. So we have a fairly narrow focus, looking at how effective are you when your client is in the chair.
Wow. Dr. Miller, you blow my mind. Your work, just the way you're thinking about these things, and not only the way you think, but the way you can support your thinking and with the research that's out there and the research that you have done with your work. For the young clinician that's entering the field, what is probably one takeaway from this hour-long conversation that you'd like for them to know?
Did I learn this in graduate school? And if not, why? You're probably in debt. And nobody told you this?
Yeah.
Kind of
Yeah.
shocking.
And, just a personal story. I remember bringing you up to a senior person in the field, and they were like, "Oh, Scott Miller, yeah, I know about him," and almost like kind of like, "Yeah, don't like like the vibe I got was like very like, we're gonna shut that down, and to me that just kind of affirmed my own beliefs of in some ways like lifting the veil, right? And I'm like, wow, there's almost like I don't want to say there's an effort to kind of snuff you out in a way, but it just seemed like it was like, we're not going to talk about that here, like we're in our world, that's a whole different world, and you either you're here or and if you're not here, then we don't really want to. And so just wanted to share that with you, that I just want to say thank you from the bottom of my heart for you being out here, sharing your research, and really trying to expand people's consciousness, expand their minds into improving and being more effective, because at the end of the day, we all join this field to help people, and why not be the best we can at it, so
let's be better than we were.
Absolutely. Dr. Miller, this has been great. I really appreciate it. If somebody that wanted to start their journey with you, where can they find your work? And is there like a particular class or a book or something that they can start with?
Sure. There are lots of books. And the book that I think is the most current good place to start would be Better Results. It's published by APA. It came out in 2020. The companion volume came out in 2023, the Field Guide. But probably the single best place to visit is just my personal website. It's at scottdmiller.com.
Got it. Dr. Miller, this has been great. Thank you so much for your time. And hopefully we can do it again, maybe next year.
I'd like that.
All right. Thank you, sir.